Okay, so I'm here today to talk to you all about people with disabilities, understanding their needs and some ways to make interactions go better, and just basically how to make the client experience better for people with disabilities. My name is Rebecca Tanner. I am a program analyst for the Disability and Health Program. I'm also a research associate at the Department of Health Services Research, Management, and Policy in the College of Public Health here at UF. I have both a bachelor's degree and a master's degree in sociology. So talking about things like health disparities, equal access, things like that, this is really kind of my jam. So thank you for having me. So brief overview of what we're going to be talking about today. We're going to have an introduction to disability, not only in Florida, but also globally. We're going to be talking about health equity and what that actually means when we talk about persons with disabilities. We'll also talk about the general health of persons with disabilities and how that differs from persons without. We'll talk about the care experience and then also some communication things we need to keep in mind when talking to and talking about people with disabilities. We're going to have a couple of anecdotal, like some statements from a patient with a disability, as well as a family member and possibly a provider. We're going to talk about some resources. Now, we'll warn you up front, a lot of these resources are going to be less relevant to you, but we do make it up because we have a resource sheet specific for this presentation for this audience. So Andrea will be sending that out along with our general handout. And then finally, we'll close off with some key points, the things we'd really like you to take home to remember from this presentation. So the main acronyms you're going to be seeing today are PWD, people with disabilities or persons with disabilities, PWOD, which is persons without disabilities. Most of our data, when we talk about disability and its prevalence in Florida, comes from the Behavioral Risk Factor Surveillance System, which is a survey conducted by the CDC every year. And so we call that the BRFIS. And then finally, the Disability and Health Program, the DHP, which is who is bringing you this presentation today. So when we look at the situation worldwide, according to the World Health Organization, over 1 billion people live with some form of disability globally. This corresponds to about 15% of the global population. And of these individuals with a disability, between 100 and 190 million adults have significant functional disabilities. So this means that a large number of people who have disabilities have severe functional issues, obviously. And we do know that also as the population ages worldwide, that the rate of disability is increasing. So disability is already a significant issue now. If about 15% of the world's population has it, it's only going to become more pressing of an issue in the future. So we do know that disability disproportionately affects vulnerable populations. We know that lower income countries have a higher prevalence of disability than higher income countries. And we also know that disability is more common globally among women, older people, and children and adults who live in poverty. Unfortunately, it's not just issues of economic or being a part of a vulnerable population. When you have a disability, whoops, sorry about that. We also know that people with disabilities often do not receive needed health care when we look at things on a global scale. Half of people with disabilities cannot afford health care, and which is compared to about a third of people with without disabilities. In addition, people with disabilities are about twice as likely to find healthcare provider skills inadequate to meeting their needs. They're also more than 4 times likely to report being treated badly and nearly 3 times more likely to be denied needed healthcare. Unfortunately, it doesn't just affect the ability to get healthcare, it affects a lot of other areas of life. We see this with children who have disabilities. Globally, there's a significant difference in access to education depending on disability status. Children in general with disabilities are less likely to attend school overall. We also know that education completion gaps are found across all age groups and in all countries, with a pattern more pronounced in poor countries. So for instance, the difference between children with disabilities and children without disabilities completing their education is about 10% different in India compared to about 60% different in Indonesia. And so these educational disparities can have some severe long-term outcomes, severe long-term negative outcomes. Disability also affects employment. So people with disabilities in general are more likely to be employed, are more likely to be unemployed than people without disabilities. This is true for both men and women. And the absolute difference for each group is for women, it's about 10% absolutely, a 10% absolute difference. At 20 to 30, from 20% for women with disabilities to 30% for women without disabilities. For men, about 53% of men with disabilities are employed compared to about 65% of men without disabilities. And again, so you see kind of a compounding effect of what goes on. So you see education puts people on a worse trajectory. You then see it replicated with access to employment. And finally, you end up in a situation where people with disabilities are much more economically vulnerable to poverty than people without disabilities. So they're more likely to live in worse housing conditions, so less likely to have access to safe water and sanitation, insufficient food, and poor housing. And so because of the extra costs with medical care, which sometimes we don't always think of with disabilities, for instance, the cost of additional medical care, assistive devices, caregivers, even when people with disabilities have the same income as a person without a disability, they are poorer. They are unable to build wealth the same way that people with disabilities or people without disabilities can. So that's the situation globally. And so now let's zero in on Florida. So what do we, Florida has a reputation as being, like nicely, we'll say, a haven for the elderly, maybe a little less nicely, more snarkily say God's waiting room. But Florida actually does not perform overly well when we look at state rankings for disability and long-term care services. So Florida ranked number 46 in a long-term care services state ranking by the ARP, Commonwealth Fund, and SCAN Foundation. This survey, or this state ranking, looked at elements such as caregiver support, availability of long-term care services, and quality of care. We ranked number 34 in the United Cerebral Palsy State Rankings of Disability Services. And so that's not as bad, but I mean, it's really still pretty middling. So this is a problem because when we look at the proportion or the prevalence of disability in Florida, it's, nearly a third of people over the age of 18 have a disability in Florida. And it rises to nearly 39% when we talk about Floridians over the age of 65. So these are some pretty high numbers. And so these kind of services that we seem to fall behind in, or at the back or at the middle of the pack, these really make a difference for people when you have so many people with disabilities. So health is central to human happiness and well-being, and it is affected by where people live, learn, work, play. According to the World Health Organization, health also makes an important contribution to economic progress. So what do I mean when we talk about health equity? So the CDC defines health equity as a condition where everyone has the opportunity to be as healthy as possible. It's really important to understand that we're not talking about everybody is equally healthy. What we're talking about is, given a person's condition, they have opportunities to be, or given their situation in life, they have the same opportunity to be as healthy as possible, or that they have the opportunity to be as healthy as possible. And so the converse of health equity is health disparities, which are differences in health outcomes and causes based on differences or based on group differences. So for instance, people with disabilities are much more likely to rate their health as fair or poor compared to people without disabilities. So the WHO recommends trying to improve health equity by tackling 3 areas. First, they recommend improving daily life conditions by encouraging communities to be accessible, and also by removing barriers in the environment that prevent people from being able to engage more fully with the world around them. They also recommend addressing the inequitable distribution of resources by increasing healthcare, needed and appropriate healthcare for people with disabilities, along with education and work opportunities. And finally, they recommend raising awareness about the determinants of health for people with disabilities by increasing their the inclusion of people with disabilities in public health data collection efforts, as well as the expansion of disability and health training opportunities for healthcare professionals. It's really pretty stunning how little exposure med school students actually get to disability-related issues. There's virtually none, and this really kind of it exemplifies larger social forces that increase the likelihood of negative outcomes for people with disabilities. So when we talk about disability in Florida, we're talking really about functional disability and the ability to engage in particular activities with or without a disability. So what we look at, the most frequently reported functional disability in Florida was a person has a serious difficulty walking or climbing stairs at about 16%, and then about 13% was having serious difficulty concentrating, remembering, or making decisions due to a physical, mental, or emotional condition. So these are kind of the top two functional limitations. We also have people who are deaf or hard of hearing. We have doing errands alone, people who are blind or have serious difficulty seeing, and then finally have difficulty dressing or bathing. So when we talk about disability now, this is not only the definition of how we talk about it in Florida, it's what we see that's been adopted both by the US Census. These questions originally actually came from the American Community Survey conducted by the Census. And this is the definition that the CDC uses when they talk about the national prevalence or state prevalences of disability. So like I said earlier, we've got a situation where, in general, we know that people with disability are much more likely to report fair or poor general health. We see this quite starkly here in the graph. In the 2019 BRFIS, 44.5% of people with disabilities reported having fair or poor general health compared to 7.5% of people without disabilities. Now that's a really significant difference. We might want to think that, oh, well, it's because their disability causes, all their health problems and that's why, but that's not always the case. People end up having worse general health for a lot of reasons, not just because of the presence of a disability. But the disability, there's clearly something that exacerbates that here. We also see some significant differences when we look at days during the past month that poor physical or mental health prevented a person from engaging in usual activities. So when we look at, for people who responded that there were no days that they were prevented from engaging in usual activities, it was 65% of people without disabilities that reported no days versus only 37% of people with disabilities. When we look at the opposite end of the scale at 14 or more days, about 34.5% reported 14 or more days, so 2 weeks out of the month or more, where they were unable to engage in usual activities, compared to less than 5% of people without disabilities. So as you can see here, there's some pretty significant disparities going on for people with disabilities. Now we're going to move on to talk about the care experience and communication for people with disabilities. So in 2015, we asked about what barriers to care people encountered when they go to a doctor. So about 41% of people with a disability reported having at least one barrier. Most common was difficulty getting onto an exam table. And the second most common was difficulty finding a doctor that understands your health condition. Now, these two are probably less important to you, but some of the other ones certainly are when you think about the environment that you're going to be practicing in. So transportation difficulties was a common problem for people. Difficulty communicating or talking with the doctor, and difficulty getting into a building or getting into an exam room. So we have to keep in mind that all these physical barriers still do exist that sometimes we don't even think about, but they can provide real barriers for people seeking services. In addition, we tend to see people with disabilities being more likely to report problems with the healthcare experience when they do receive healthcare. So when we looked at the impressions of physician respectfulness according to disability status, we see some interesting results. First, by and large, the overwhelming majority of both people with and without disabilities report high levels of experience of physician respectfulness. However, when we look at the numbers of who report sometimes or never, even though there seems like a small absolute difference between those two, the relative difference is actually about 35% between people with disabilities and without disabilities in reporting not feeling respected by their physicians. Again, when we look at physician attentiveness, how carefully does the doctor listen to you? Again, we see overwhelming majority say it's great. But again, the devil is in the sometimes and never category, where people don't feel that their doctor listens to them. Again, what seems like a small absolute percentage difference actually comes out to about 41%. People with disabilities are 41% more likely to report being not listened to carefully. Again, as with the last two slides, we see the same basic pattern going on here. In this category, for the clarity of explanations, we see an absolute difference going on of 31% between people with and without disabilities when it comes to feeling like their doctor sometimes or never gives clear, concise explanations. So, when we look at these differences, these overall relative differences between people with and without disabilities who report positive experiences, what I want to point out here is that how we look at the data matters. So if we were to look at the relative difference for people with and without disabilities for the always and usually category, you'd see about a 5% relative difference between those two. So you're thinking like, great, that's great. There's nothing going on, nothing to see here, everything's fine. But again, where the disparity is really showing up is in the larger differences between the sometimes and the never, or the sometimes never. When these are such strong absolute differences here, what you're seeing is evidence of a health disparity. But this is something to keep in mind in general, that when you look at data, look at what they're comparing in terms of relative differences. Because this kind of presentation does influence the message you're likely to come away from it. And in this case, for all three of these experience questions, the always and usually the relative difference was between 4.5% and 6% for these three variables. So data presentation matters. This is another example of how people can lie with statistics or present skewed information by statistics. So, but again, we think that the numbers of the sometimes and never with a care experience where they don't feel like they've had good care experiences are indicative that there is actually a health disparity going on. So according to the CDC, so actually before we move on to this, why do you guys think it matters? Why do disparities in experience and all that matter, particularly for you as veterinarians, vet techs, vet students, staff at clinics? Why does this matter to you? Somebody talk to me. Yes, raised hand, Katie Houston. I have to figure out how to do this.
I don't know if you can see me all right, but I guess why it's important to me is just treating people like people at the end of the day, and with empathy and kindness. It goes a long way of even just relating to their pet of like, we're here, we're gonna figure things out and it's gonna be okay.
Mm-hmm. What else? What do other people think? Tell me more.
I think also not just able people benefit from the human-animal bond, and we have to recognize that everyone experiences that bond and everyone deserves to have a good experience when they come to the veterinarian, and we take their concerns seriously, and we don't, we do it right. We do it right.
Yeah. Claudia, are there any in the chat that people have mentioned? I'm going to have you monitor the chat if you could for me.
Sure. I would also say from like a business aspect, the population you'll be able to reach if you're more like willing to work with people who have disabilities or they feel comfortable in your practice, I think you're going to reach a broader audience. And then kind of connecting that to kind of like pet health and ethical considerations. So like if you're able to reach those people, you're reaching more animals and more pets that are going to have better welfare overall.
Yep. Any other thoughts?
Well, hi, I'm Allison Hinchcliffe. My mother is deaf, like profoundly deaf since she was a baby. And, you know, I've seen our pet's health suffer because she has difficulty contacting her veterinarian. I've actually been doing research about it and stuff. So hopefully we're going to get somewhere with it. But it's really important. It's a human rights issue, you know, it's not something we can ignore. And it's actually, we legally have to provide equal services, you know, by the Americans with Disability Act, you know?
There's something that underlies kind of what everybody is talking about in this case. And it is the social and cultural attitudes that we have to overcome, that we have been raised in, pretty much no matter where we're from, that have led to this sort of belief that people with disabilities are less than. They're less than an individual who does not have a disability. And this can lead to, as some people said, withholding of basic human respect. It also, you know, they can be viewed as something as more of an object to be pitied, you know, someone who is quote unquote handicapped in the race of life. And so while the language over the last century has evolved to focus on disability, for many people, this idea is still really prevalent. Like for a lot of people, this underscores, like this is the bedrock of their beliefs about people with disabilities. And so just as we have unconscious biases related to people of different races and ethnicities, different ages and sexes, a project implicit at Harvard does have an unconscious bias test related to disability. So that might be something people are interested in. If you're interested in, do it. But we have to overcome these sort of unconscious biases. And because we, as veterinarians and people who work in clinics with, who might be working with clients with disabilities, you're going to have to overcome some of these same unconscious and even some conscious biases to provide the best services you can. And so it's important to be aware of how they impact you and your assumptions of how people are able to care for their animals. This is something in general that I think, like in my experience, some vets have just basically said, well, you know, walk your dog this length of time, give them this medicine every 8 hours, you know, this kind of stuff. But you really need to be able to take into account not just what you think people can or cannot do, but you really have to think about, you know, what other obstacles stand in the way of being able to do this? And, you know, for someone who, for instance, has a companion animal and the person uses a wheelchair, you might not believe they would be able to, you know, walk their dog, exercise their dog, but they could. You might look at somebody who has an invisible disability, like a heart condition, where they can't walk their dogs very far. You might look at them and just assume they're capable of walking. So it's really important that we kind of check our assumptions at the door. And this is true, like I said, both for people with and without disabilities. But this is often a really significant issue for people with disabilities, is the underestimation of what they can actually do. So, and again, just in general, if you're a person with a disability and you have poor care experiences or difficulty accessing care, you know, that has long-term ramifications on your health. And those long-term ramifications on your health have an impact on how well you are able to take care of your animals. So it's really important that why we need to address these health disparities, both at the veterinary practice level for clients, as well as in the larger healthcare milieu that we're working in. So moving on to this slide. We know that according to the CDC, people with disabilities are more likely to have poor overall health. They're less likely to receive quality and timely health care, and they're also routinely excluded from health promotion and prevention efforts. So the disability community is really trying to change this. They're really pushing to be more, to help address these disparities and to increase non-token participation in health promotion efforts. So it can be kind of summed up by the phrase, nothing about us without us. So this involves not just, here's a token picture of a person in a wheelchair to show like, look, this is how woke and diverse we are. It's to actually talk to people with disabilities, make content and show images that are relevant to them. Like if you're creating something, creating a newsletter about like my veterinary practice has a newsletter, monthly newsletter. So does the pet insurance we have. Yeah, but if you want to be inclusive in something like that, and you're talking about, tips to exercise your dogs, not just show a picture of a person who uses like a cane that the blind people use, or someone in a wheelchair, actually have some tips for them, like what to do, how to make it easier for them. Do things like that that actually speak to their needs, and they're much more likely to engage with the material, because if they see something about walking their dogs and it's all for people who can walk long distances, or who are able to walk for 40, 50, 60 minutes, they're going to shut it off. They're not going to engage with it. They're not going to look at it. And so that's why really kind of focusing on actual inclusive health promotion and prevention efforts are so important. You don't include them, they're not going to see it as relevant, and they're not going to engage in it. And this can be true for, like I said, taking care of pets in a myriad of ways. So now we're going to, let's see. So now we're going to move on to talk about some communication issues, the evolution of language, and some interaction tips for how we want to deal with for best ways to deal or to interact with people with disabilities. So there are a few key things to keep in mind. First, it's important to speak to a person with a disability like you would speak to anyone else. This seems really obvious, but it's not. Unfortunately, a lot of people shout, they talk more slowly, they talk in a more patronizing way. They do a lot of this kind of stuff, and it's maybe not really deliberate. They might not even really be aware they're doing it, but it's projecting this bias about how we see people with disabilities. Again, if a person is accompanied by a caregiver or interpreter, you really need to focus on speaking directly to your client, the person with a disability. It's really disrespectful not to, and that is the kind of thing that really that understandably upsets people with disabilities. It's like if you're a woman, you and your husband are going car shopping, or you and your partner going car shopping, and the salesman talks to him the entire time when the car is for you. I have had that experience. I am still mad about it 7 years later. So we want to be respectful and speak to people directly. And it can be hard. I'm not going to lie about that. It can be hard, especially if it's an interpreter. But this is again an issue of you practicing. You also want to use respectful disability language. Avoid phrases that are kind of outmoded, such as suffers from or crippled. We'll talk a little bit more about that on the next couple slides. So, learning respectful disability language is important. Because can you imagine, living your entire life having to explain to people why, if you've got a cognitive or intellectual disability, being referred to as a retard or as retarded is offensive? I mean, like, that's a really obvious example, but think about how offensive that is. And what we've seen over time is the evolution of language related to disabilities devolve into more general derogatory language. And people with disabilities want respect and acceptance, just like anybody else. And so it's really important to kind of understand how some of our old language is derogatory, even if we don't necessarily realize it. And we also need to remember that many people who don't have a disability right now might end up with one in the future. If you are lucky and you don't ever develop a disability, whether temporary or a short-term or long-term over the course of your life, you're likely, you're going to have a friend or a family member, someone you care about that is going to develop one at some time. Disability really does affect everyone. It's not just an issue of, do I have it, but it's, do people I care about have it? And so we think about how we want to talk, how we want them to be talked about and how we want them to be treated. And so it's really important to kind of learn this sort of more respectful language so that so you can reflect that basic respect you would want yourself or your friends or family to get. So a lot of the language used around disability, it might, like I said, have been historically used appropriately, but as time has gone on, it's become derogatory. Like I said, with the use of the word retard, at some point, back in the 50s, that was the word. But as language has evolved, it's become horrifically offensive, just in general use, and much less to refer to someone with a cognitive or an intellectual or developmental disability as retarded. So that's a really good example of the kind of things we don't want to do. So when you think about updating your language, the other thing we want to really think about before we move on to some of these actual other terms is to think about talking about a person with a disability as well as talking to a person with a disability and how we do that respectfully. So examples of some outdated words like I've talked about with learning and cognitive disabilities. One you really see that can be kind of offensive is slow or special, in addition to what we've already talked about. The use of special, it can be particularly galling to people because its use tends to convey low standards, low expectations, and pity. So more respectful language would be talking about a person with a learning disability, a person with a cognitive disability, or a person with a learning or cognitive disability. So what we're seeing here is we talk about a learning disability, we talk about a person with a learning disability. So these are the kind of things that it's not only the object itself, the disability itself, but it's also about how we talk about a person with it. Mental health disabilities are another one where words like crazy, insane, nuts, likely most of these never had anything but a pejorative. Were anything but pejorative. So we really need to kind of move away from those words. Even in general, in our general use of language, not even related to specifically a person with a psychiatric or a mental health disability. So talking about psychiatric disabilities or a person with a mental health disability, this is an example of more updated language. Mobility and physical disability is another one where things have really changed. So handicapped, physically challenged, wheelchair bound, a lot of these are, again, they're outmoded. Wheelchair bound is a really interesting one because the concept of wheelchair bound really comes from the perspective of a person without a disability who does not have to use a wheelchair. And so to someone in that condition, a wheelchair seems like something that would bind you, that it limits your movement, it keeps you in one place. However, if you've got a mobility disability and you use a wheelchair, that wheelchair is what gives you freedom. The wheelchair is what allows you to get around in the world, to interact with your environment. Otherwise, you'd be stuck on a bed, on a couch, a chair. You'd be reliant on somebody to carry you where you needed to go. And so those are the kind of things we have to think about when we're thinking about what language actually means. And so when we say someone is wheelchair bound, it's a pitying and it's a limiting thing because we don't see the possibility for freedom. Instead, we're placing on them limitations. And so another one we are all familiar with at this point, now that Game of Thrones has been on and is over, is the use of the terms dwarf or midget for someone of short stature or little person. So Tyrion is probably the most famous little person, most famous character little person of all time. My favorite line was delivered by him from Game of Thrones, the I drink and I know things. That is my favorite thing ever. But we want to talk about them we want to talk about little people not as dwarfs or midgets. We want to talk about them again as people of short stature or a little person. It's a lot more respectful because dwarf and midget, it feels, that's what you'd see written on like an oldie-timey sign for, a circus, let's poke fun at these people, that kind of stuff, an oldie-timey freak show kind of thing. So we want to get away from that language. And finally, the use of how we talk about health conditions is really evolving. So old outdated language is the language of victimhood. The idea of somebody stricken with a disability, somebody who is a victim of, someone, an AIDS victim in this example here. Victim language is really disempowering because the use of a victim really takes control from someone and places really the focus on the thing that acted upon them or the thing that is acting upon them. It doesn't allow them to be the agent of their story, the hero of their story. Instead, it's just, they're responding, it's always, they can't do anything about, they're trapped. Instead, we want to talk about the language of survivorship. So the language of survivorship is something you're seeing more and more commonly. I first encountered it working at an intimate partner violence center. When you talk about a survivorship, you talk about someone living with, you talk about them enduring, you talk about them going on. This is much more empowering. Why? Because they are the agent of their story. They are the one driving their lives. They might have something, but it is not defining them in the same way that being a victim of something is. And so that's why we want to move towards more of survivorship language. So living with, just something you have rather than something tragic. What all this has in common is what's called person-first language. So person-first language was developed as, it's basically language that puts the person first as the, instead of the diagnosis. So a lot of times you see this starting to change, for instance, in medical papers, but a lot of medical papers, for instance, when you talk about, if it's on diabetes, old language would refer to somebody, the sample as diabetics. Instead, now you see more and more people with diabetes. And like I said, what this does is it places the person at the center of the description and the diagnosis second. And so what this does is it decouples this identity as a diabetic or as a person as being disabled. It decouples that feature of you from who you are. And so that's why we've started moving more towards person-first language as basic etiquette when talking about disability. However, as with everything else in life, there is some nuance here that goes on. There are some groups in the Disability Activism Committee do prefer identity-first language. So in this case, you see it quite often in the big D deaf communities and and autism activism circles. They often prefer to be referred to as deaf or autistic rather than as a person who is deaf or as a person who has autism. So it can be complicated. So how do you know what to do? So you want to listen to how the person talks about themselves, both individually and as part of a group. That can often give you some clues. If you're uncertain and the subject arises naturally somehow, you can always ask. But again, this is something that's just kind of, it's hard for it. It's going to be hard for this to come up naturally. And so finally, basically, the most important thing to do is if you don't argue with the person about what their preference is, like they like what they like, and that's fine. That's how they see themselves. It's not something to that really is a hill to die on, I guess. And if you do say something and they correct you, if you say person with autism or a person with autism and they say, no, I'm autistic, then, just, sorry, and move on. Don't, throw yourself on your sword. And because we see a lot of people doing that with other kinds of identity focus groups. So now we're going to talk about some individual communication tips based on the different types of disabilities. So for individuals in a wheelchair, you want to sit to get on eye level. This is really important. We don't often think about it, but when you remain standing when someone else is sitting, that introduces yet another subtle power dynamic where there's already a power dynamic going on, where you as a provider have more specialized information and you have access to the things people need. And so we really want to kind of avoid that when possible. So if it's possible, you know, and you come in to a room with a person in a wheelchair, you know, sit after you, you know, introduce yourself, sit, and then go on from there. Another thing that's really important to think about is that wheelchairs and crutches and other assistive devices are actually a part of personal space. So we don't want to lean on them. We don't want to take them. We don't want to do anything like that. Another item to keep in mind is that it's really important to ask before assisting. You know, polite society functions on people doing polite actions. And a lot of people just, you know, open the door for people. But if you see somebody with an obvious disability and you think they might need assistance opening the door, you know, you don't just open the door for them, ask them if they need help. You know, because people do want mastery over in their environment. People with disability are the same. And for people that can be doing things by themselves, opening doors for themselves, carrying things by themselves, you know, that kind of stuff. So it's okay if they say no. It's nothing about you. It's more just about what they want. And so, you know, accept it and move on. The only time I would say not to do this is if you see someone in an obviously dangerous situation, you know, someone who's fallen in the street, you know, traffic, that kind of thing. You also, again, want to talk directly to the person, to your client, not to a third party who may be assisting them, a spouse, a child, anybody else. Remember, your client is the one who's going to be able to answer your questions, and not, you know, best, not any of the other people. So you really want to focus on them, even if they have a disability. And then again, like we mentioned earlier, you want to treat people, you want to treat them like everyone else, because pretty much they just have a mobility or physical disability. It doesn't affect any other senses. So when you're talking about some tips for people with visual disabilities, I would recommend addressing the person by name if possible, and then introducing yourself by name. Visual cues obviously are really important in identifying people, and sometimes even people you've known for years and you talk to a lot, you don't recognize, you know, if you just hear their voice, you might not recognize them immediately. You also want to speak clearly and not shout. Again, this is an issue of, you know, treating them like everybody else. They don't have a hearing disability, so don't act like they do, I guess. You also don't want to pet or distract a service dog when they're doing their job. So obviously, if you're a vet, you're seeing, or a vet tech, and you're seeing the dog as a client, as the patient in the visit, you know, go ahead, you know, play on it, love on it, whatever. But if, for instance, someone with a disability who has a service dog is in your practice, is being seen by you for perhaps a companion, another companion pet. At that point, let the dog do the dog. Let the service dog do the job. That way, because like I said, they do important jobs for people. So you want to announce yourself when you're leaving the conversation. Again, this is an issue of visual cues where people might not be able to see, you know, the kind of physical cues that indicate we're kind of like wrapping things up. That often happen before we finally say, well, see you later. So just let them know that you're leaving so they're not talking to dead air. And then finally, you want to alert people to posted information that they can't see. This is important because people with visual disabilities have to be able to see, they have the right to the same information that people without a visual disability have. And if you don't tell them what's on signs, then they're not going to know. So now we're going to talk about hearing disabilities. You want to gain the person's attention before speaking by waving, giving some sort of physical indication that you want to talk to them. You also want to face the person and keep eye contact. Again, you want to make sure they know that you're focused on, you're talking to them. You also don't want to cover your mouth because some people do lip read. And in fact, in general, lip reading helps with auditory processing for pretty much everybody. So keep your mouth clean, or keep a clear view of your mouth. I mean, obviously keep it clean, but anyway, keep an even volume, don't shout. Shouting often does not help. And when you shout or speak too loudly, you can end up embarrassing somebody or, you know, accidentally revealing information you don't mean to. So if you want to actually communicate with someone who is hard of hearing, but not completely deaf, one thing that I would recommend doing is actually try speaking in a lower tone. People, my understanding for people who start to lose their hearing, they often start to lose it at higher tones first. And so speaking in a lower register might enable them to hear you better. If you don't understand something that they said, again, ask them to repeat it or write it down. We don't want to pretend to understand. And not pretending to understand is going to be a through line in several of these upcoming slides. This is how mistakes happen, is by pretending to understand, so that way you don't feel embarrassed yourself, you don't embarrass them, but it's really important that information is conveyed accurately. So if you have to, ask them to convey it some other way, ask them to repeat it, but don't pretend. You also want to hire certified ASL interpreters and then speak to the person, not the interpreter. So the onus is on in this case, the veterinary practice or the college of vet med, whoever, to provide a certified interpreter when one is requested. There's local centers for independent living that can help hook you up with one. It costs somewhere around $120 an hour or so, I think. There are tax breaks for doing it, but remember, it is on you. And sometimes, people, you might think, well, but, they have a spouse with them and they speak ASL, so that should be good enough. We don't need to do it if that person comes with them. Well, no. In 2017, during the run up to Hurricane Irma, one of the counties in Florida had an emergency briefing where there was an ASL interpreter. And it seems great, right? We're telling people what they need to know, and we're getting it out to everybody. Well, the guy wasn't a certified interpreter. His brother was deaf, so he knew some ASL, and it was a disaster. He was signing about pizza bear monsters. There were random strings of numbers and letters. I mean, it's almost kind of comically offensive how badly it went. So that's why it's important to have someone who's certified. And then again, be aware of phone relay services. Phone relay services often sound like the connection of a telemarketer scam call when the computer clicks over to connect. So it's really important that you just give a little bit of extra time to make sure it is actually a spam call and that you're not missing somebody who is trying to call on a relay service. So another thing for some things to keep in mind for people with speech disabilities includes being patient. People with speech disabilities can often take them a little bit longer to answer. So give them some time. They're not being difficult. They just need some time to formulate and get out the answer. If they use communications devices, they might have instructions that could tell you that explain how to use them to communicate with them. So ask for help if you need to. Again, speak in your regular tone of voice. Nothing prevents them from understanding. Again, tell them if you don't understand what they're trying to say. Have them tell you a different way, repeat it, whatever you have to do to get that accurate information. And another thing to consider is to ask short questions that require brief answers or head nods so that people don't have to, it reduces the burden on the person to answer, and it makes it a better experience both for you and for your client. And so finally, for individuals with cognitive and intellectual disabilities, you're going to run into some of the same tips for interaction that we discussed earlier. You want to give them time to respond to your statements. It's not that they're ignoring you or don't understand you. Sometimes it takes the brain some time to formulate a response. You also want to keep your conversation simple and easy to understand. So you want to avoid acronyms, metaphors, and puns. Again, don't pretend to understand. Ask the person to repeat it. This is one of those situations where if you have repeatedly tried and you just cannot understand what is being said and there's a caregiver present, at that point, I would ask the person, they know the person better. They're much more likely to understand how they communicate. And so that is one case where it would be acceptable, but it should be a last resort, not your first resort. And then finally, we want to treat an adult like an adult. A lot of individuals with cognitive and intellectual and developmental disabilities report being infantilized in their interactions with other people. And, they deserve respect just like any other adult. So it's really important that we treat them as adults. So we're going to go over a couple stories. I am running much later on time than I thought I would be. So I'm going to run through just a couple of these. some experiences of people with disabilities. So TR said, she talked about, I went to my new primary doctor and he told my husband about, and he talked to my husband about me in front of me. Then when my husband told him that he could speak to me, he then started talking loudly and slowly, like I was deaf or mentally challenged. He also stood over me instead of getting on my level, which is somewhat intimidating. So that's some of the things like we talked about, like kind of things that we want to make sure we do, or in this case that we don't do. And then Christine says,
I would like medical professionals to take the time to ask about how my cerebral palsy specifically affects.
oh, shoot, sorry. So we'll go on ahead and read that one. I would like medical professionals to take the time to ask about how my cerebral palsy specifically affects me. To help give me a plan of care that suits my specific needs. I have been stereotyped due to my physical limitations on the ability to take care of my infant son by medical providers, and have also had medical professionals and their staff ask questions about me in front of me, as if I can't communicate or speak for myself. The one piece of advice I would give medical professionals is to know that disability isn't necessarily what you read in a textbook, and that disability affects each person differently. So get to know your patient before providing their care. And then finally, feedback from a family member actually talked about some interactions with physicians. And she said her family member was disrespected and disempowered. He was literally treated like he had no value at a time he needed the most compassion. And she said, it is sad when we think that the ones we care about who are fully functional see them treated unkindly. They have difficulty putting what they feel into words. Imagine what it must be like for a person who cannot express it verbally. I could not even imagine being a patient. It hurts so much just watching from a distance. So this is what it can be like for people with disabilities. So we talk a lot about these tips, but you see these tips really do come from the experience of people with disabilities. So a brief overview of resources. The Department of Health has a physical activity and fitness flyer for people with disabilities. I was also going to show part of a video. I will just show real quick a brief part about outdoor exercise for people with disabilities. The nice thing about this video is that it actually shows not only the developers and the creators and narrators of the video have, some of them have disabilities, but it's really focused on the needs of people with disabilities. So let's see if I can hit the right place.
Principles apply.
Let me go forward just a little.
You also still want to have a warm-up, exercise, and cool-down phase. One of the easiest ways to exercise outdoors is by going for a walk. Walking can mean many different things to different people. Some people may walk using their legs, while some people use a wheelchair, and others may use sticks, crutches, or canes. But regardless of how you walk, it can be a great way to get cardiovascular exercise. If you don't live in an area where you can just go for a walk right out your front door, you can always go to a local park or walking trail. Florida has numerous walking and hiking trails all throughout the state. To find one near you and note its accessibility, you can go to floridahikes.com and search accessible trails. To find more information on exercising with a disability, feel free to visit the National Center on Health, Physical Activity, and Disability.
So I really like that video because, like I said earlier, one of the narrators she's got a physical disability. She uses a wheelchair. In the video, they show people participating in activities not only with just a token disability, maybe a person in a wheelchair, but they also show somebody using, for instance, a walker. They talk about, in the part we briefly saw before I fast forwarded, they showed some accessible water sports, the use of an accessible water ski for people who are unable to use standard water skis. So this is a really good example of what actual meaningful inclusive material looks like. And so this is something to kind of keep in mind as you go forward with either being an office manager in a practice, running a practice, that it's really important to have meaningful representation for people with disabilities to make them feel like your advice is relevant to them and that they are part of your audience. So again, this is the Healthy Eating and Weight Tips by DOH. It's here. We can get you a copy if you want. The Disability and Health Program, I do want to quickly mention, it's going to be less relevant as for you as your clients, but in the event that you or a family member or friend are in the position where they want to apply for Social Security disability, the Division of Disability Determinations housed at the Department of Health is one of the first steps in getting you certified to be able to get onto Social Security disability. So this is a good thing to know about. The FDOH, the Florida Office on Disability and Health, it just has some information on disability. It has some training resources in the US. It talks about basically, some of the stuff that the state and UF have kind of partnered up to do. And then finally, I want to briefly address the ADA checklist for existing facilities. So this is something we've heard a lot about that people want to know more about because physical accessibility and the ADA feels like such a massive thing. So the ADA requires state and local governments, businesses, and nonprofit organizations to provide goods, services, and programs to people with disabilities on an equal basis with the rest of the public. Some people think that this is only required of new construction and that older buildings and facilities are grandfathered in, and that is not the case. It's important to remember that the ADA is a civil rights law. It's not building code. So all buildings have to be able to accommodate, have accommodations for people with disabilities in an ideal world without, so the ADA checklist for existing facilities is categorized into 4 priority areas. So you have approach and entrance, access to goods and services, toilet rooms, and then kind of additional issues such as phones or relay receivers. So based on the 4 priority areas, there's a wide range of topics. So looking at one specifically, priority 1, approach and interest. This one covers a lot of things. So for instance, it includes accessible parking spaces. And this is how we talk about parking spaces right now. Because if you think about like what it actually means to say a handicap parking spot or a disabled parking spot, I mean, the spot's not handicapped, the spot's not disabled. It is, however, accessible. And so when you think about it, we want to identify the thing by the thing it actually is. And so now we talk about it as accessible parking. Another example of some of the ADA mandated characteristics is a maximum door pull weight, for instance, has to be no more than 5 pounds. So you also have to have ADA mandates, knobs that somebody doesn't have to make to wrap their hand around to use. So they have to use like a lever knob. That's another example of an ADA compliant accessible door. For wheelchair ramps, you have to have 12 inches of rise or 12 inches of run for every inch of rise. So this is the kind of detail that the ADA gets into. And now a lot of people seem to be under the impression that being compliant with the ADA means expensive, huge renovations, but it doesn't. For instance, putting a stack of paper towels onto the counter next to a sink in the bathroom makes accommodations for people who might not be able to easily use a conventional paper towel dispenser. Another example of a cheap fix is to rearrange furniture in the waiting room so there is space for a wheelchair user to wait, or for having at least one, but preferably more than one room where people with disabilities would be able to easily get in and out. So for instance, if your exam room has a chair in it and you have a client in a wheelchair, removing the chair from the room makes that room more accessible for your client. So these are not all the fixes are high dollar fixes. And so it's crucial to remember that the ADA is the bare minimum. You may still be inaccessible. Having a staff that is unwilling to meet the needs of people with disabilities because they might feel it is too much effort or that they're not worth it, that can make facilities inaccessible. Individuals who won't wait to see if a call is from a relay service rather than a telemarketer, that's another example of being inaccessible. Not informing people who are blind or low vision of information that's posted is another example. And finally, being unable or being unwilling to engage with a client or patient and preferring to interact or speak with a third party is another example of being inaccessible. So accessibility really does involve more than just the built environment. So the key points that we want to take home are that we recognize any unconscious or conscious biases, stereotypes, and negative opinions you hold about people with disability and kind of actively interrogate them. You know, learn more about disability and the history of how our cultural understanding of disability has evolved. This kind of opens your eyes to a lot of where some of these cultural attitudes come from. And finally, we also need to remember that disability, whether it is a short or long-term disability, will impact you, a family member, or a friend at some point. Nobody gets away from it. We also need to remember that accessibility is not just about having an ADA compliant physical space. How the frontline staff, techs, and vets interact with patients also has a significant impact on your accessibility. And then a few key interaction tips that we feel are particularly important is, again, to do not talk to caregivers or translators who may be accompanying your client unless no other way to communicate is possible and you have made the attempt and failed in your efforts. You also want to discuss with clients the potential for any limitations in the ability to care for their pets, and you don't want to make assumptions about what they can or cannot do. This one in general is a good idea to do for everybody. So kind of I would think that's just the best practice thing. People with disabilities also deserve to be treated with the respect and consideration you would show clients without disabilities. Again, we want to be careful of building in pity or low expectations into how we interact with people with disabilities. And finally, again, don't speak more slowly, loudly, or in a more patronizing manner than you would to someone who does not have a disability. Again, this is an issue of respect right here. So those would be the key take-home points that I would have you go away with. So real briefly, we are funded by the CDC, and we work with Department of Health. So does anybody have any questions? I see there was some activity in the chat, but when I tried to look at it, I accidentally forwarded my slides a bunch. So I'm going to stop sharing now. And so let's see. Does anybody have any questions first before we look at anything from the chat?
Feel free to unmute yourself as well if you guys have a question. Thank you so much, Rebecca, as well, for being here and taking the time to join us today.
I was a little more frazzled than normal, so I'm sorry if it seemed a little jumpy.
Technology. Also, we had 96 participants at one time. So thank you to everyone who came. That's amazing.
So, okay. So yeah, so we do have some people who talked about with disparities, people are less willing to return for care. Confidence and trust in a health professional is really important. So these are also some more of the reasons why we care about these things. Again, education is really important for understanding these issues because the culture just does not tell us that people with disabilities really are worthy of much thought or respect.
Yeah. Katie, I saw you unmuted yourself.
Yeah, sorry about
do you
that.
mind if I ask? No, please, no sorries at all. I was wondering if there's any data or research done on possibly I guess applying what we're good at, which is maybe holding a low-cost vaccine clinic and working with human physicians to provide flu shots, just maybe bare minimum care in terms of, I guess, accessibility and bringing communities together. Are you aware of any research going into programming like that? Funding at the very least?
I'm not aware of anything like that, because what you tend to see a lot of times is professions are so siloed anymore, but that might be something that would be worth reaching out to. The college of medicine does have a low-income free clinic. So that might be something actually that if someone was interested in doing that, they could reach out to them being like, hey, how can we help? you know. So that would be one way to do it. I don't, again, though, I don't know if there's any research on that, but the cross utilization of the skills, I mean, it's, you know, like you said, it's an obvious like opportunity to actually do something to help people. So I do like that idea.
Thank you for your time.
Yeah, I'll mention it to Brian at DOH to see if that's something that would ever be, you know, kind of something that would be feasible.
Possible.
So
Okay.
yeah. So thank you.
Thank you. Hope you have a great night.
Thanks, you too.
I had a question because I found this very informative. I'm actually in Colorado. My name is Lynn, and I was wondering, do you do these talks often? Is this something that you do for different health professions? And I would be interested in setting something up for our school as well.
Yeah. Right now, we've kind of been knocking around student and professional groups around UF and in Gainesville. Taking it to a larger audience is something we're discussing. We're in the process of having the presentation added to the Florida Department of Health's website. And with the sudden increase in and acceptance of Zoom for things, we are planning on, assuming the funding, you know, the carry forward goes through, we would continue to do this, and looking to do it in other locations is definitely something we want to do. So we would be able to do that. The only thing, I mean, it's just, you know, something you need enough advance notice so I can, you know, pull actual numbers for Colorado, because you don't really care what's going on in Florida. But that would definitely be something we can do. So you can send me an email. If I need to, I can put it in the chat again.
I'd love that. Yeah.
Okay, yeah, let me put it on the chat.
Also, while you're doing that, Claudia was just reminding us about the post-test.
Oh yeah, dang, do the post-test. Like if you did a pre-test and you want to do the post-test, that would be wonderful.
Is it the same link?
No, it is a separate link. Let me share my screen again real quick, because I completely forgot about that in my rush to like talk to everybody. So
Also, this is being recorded, so
Ooh.
Linda, right, from Colorado? I'm so sorry, I might have.
Yeah, no worries.
Well, I'll make sure to share the link from wherever you saw. I'm not sure where you found the info from, but I'll share the link for the presentation.
It was posted on the Voice National site.
Voice. Okay, perfect. Yeah. So I'll share the link there for sure, so you can have this information.
Yeah.
Okay.
So here's the QR code. I can, let's see if I can, let me see if I can pull up the chat and put in the bit.ly link. Sorry. I'm not a faculty or a teacher, and I'm just kind of like, I do my own thing. So Zoom and I are not like friendly. So let me go down to the bottom. Oop. Let's see. Okay, here, I'm going to grab the bit.ly right now. And again, this is only open for 15 minutes because I was dumb and didn't put it in to keep it open longer for presentations like this. We limited it to 15 minutes before and after. So, but yeah, so if you're going to do it, get it done quick. I just posted the link, and let's see if I can copy the QR code into the chat. No.
Also, I'd like to mention that Dr. Bowie put the link for the Harvard implicit test, implicit bias test, if you guys want to check that out as well.
I have a question, Becca, if that's okay.
Yeah. Oh yeah.
Yeah. So, question: have they done any studies on students who use the Disability Affairs Office who make the decision not to go into the health professions because they believe that the health professions is not accessible enough for them to be able to major, for example, in that particular profession?
I would be willing to bet there is definitely literature. Like, I don't know it personally, but I would be really surprised if there's not information, some studies on that for students who considered medical school. But I don't have access to anything like that right now. if you want to send me your email, I can do a quick and dirty PubMed search and see if I can find something for you. So you can just drop that in a DM to me if you want.
Okay.
I also just kind of bouncing off of Dr. Bui, but not really, because when we talk about, you know, like LGBTQ plus affairs and whatnot, one example that they always give us is to put like a little rainbow flag in like the door of our clinics to show that we are accepting of all LGBTQ peoples. Is there some sort of, you know, we don't want to show a symbol without the training, of course. Like if our staff, if at our vet clinic, like we all received some sort of disability training, is there like a certification or a symbol that we can put in our clinic, whether that be like on the door or on our website or on our Instagram, whatever, to show people with disabilities that we are working for them? Do you happen to know?
Let me Google real quick and I'll see what I can find. My favorite part of my job is actually problem solving and finding information. So
we also had another question while you're looking that up. They said, Becca, do you have any advice if encountering pushback when trying to make accessibility or language more inclusive?
Yeah, pushback is a big one. People don't like change, you often see. The best way, I think, really to do it is to like, my first recommendation is always model the language. If they continue to use inappropriate language, then I would say, hey, you know, this can be, you know, this can be offensive to people. Don't, a lot of times, you know, it's an element of call out culture that is highly, that people have disagreements about, is the utility of calling someone out, how you do it. And so in general, I think people who are going to be more resistant are better to be handled with a gentler approach, like, hey, when I've talked to people like who are, have developmental disabilities, for instance, and that word is can be really offensive to them, and you just explain that and a gentle approach will sometimes help, but sometimes, I mean, this is the thing, like sometimes you're not going to win. Backlash is a real thing, and modeling the language and the behavior is the most low conflict way to do it. But I would just, tread gently, I think, when you try and talk to someone about offensive language, and just try to be like, hey, it's like that sandwich thing, a positive and a positive, put the negative in between two positive things or something like that.
The compliment sandwich.
I am totally spitballing here, you guys.
I also wanted to add on that, because something that Shelly said at the beginning of this was the huge business aspect of this. And like, I've worked with countless of like older veterinarians who like are very stick to their ways. And I really like that Shelly brought the perspective that there is a huge business impact for this. And I feel like they might take that more to heart and see it as a more like logical thing than like you coming personally for them because of what they, I've been talking like this my whole life type of thing. So I just wanted to bring that up because I literally wrote that down because that was a great point.
Yeah. No, it's interesting, because on the one hand, rationally, the business impact, you want that to have an effect. But when you look about like actually at the history of employment discrimination or discrimination in use of facilities based on race and ethnicity, you don't see that. And so appealing to their bottom line is always going to be, if appealing to their sense of like, it's kind of rude to talk to people that way. And, like we really want to, these people need our, our services, and we can do really good by them. If you have to appeal to the bottom line, go for it.
Yeah.
And one of the resources we're sending, that we've sent Andrea to send out to the attendees, is actually an article from the Harvard Business Review it's actually about like why making your workplace more friendly to employees with disabilities, like a business case for it. So that's something also that, you could present. when it comes to, changing policies or changing workplace norms and attitudes. When it comes to, like, for instance, employees with disabilities. And usually once you start in one area like that, you start to, some of these changes flow outwards just as naturally. A lot of times people who engage with, who don't engage well with people with disabilities, sometimes it's active, like, you're not worth it. And sometimes it's just like they've never even really thought about it. How their language might occur or how their language might sound to someone with a disability just never occurs to them. Same with like a relay device. If your front office staff has never been told that this is a thing, then they don't know to listen for it. So a lot of times you start exposing businesses to aspects in one area, it bleeds over into others, just as awareness generally increases.
Right.
So.
I know that there was a presentation I'm so sorry that was talking about how there are vet schools that are changing their, and I'm sure Madison, I'm sure you know a little bit about this better. I think it was Ohio State that changed the requirements for like the student objectives. So for example, instead of saying like the student will speak clearly to the client, it would say like the student will communicate to the client, if it was a person who was deaf or hard of hearing. And I think it's interesting that VetMed really takes these strides when our patient is always, the canine horse, etc., but our client will be the person with a disability. So I thought that was interesting.
And well, when we discussed it yesterday, you and I, you mentioned that it's basically like a pediatrician. The patient is the pet, just like as a pediatrician, your patient is the child, but the client is really always, the person with the disability or the parent. So that was a really actually good way to kind of like frame it for me too, because I had never really thought about that sort of,
And if I could just chime in, just kind of like as a personal experience as someone who is hard of hearing, not only have I communicated and had like really, really bad experiences with clients and other people in working environments, because as a person, I seem like I don't have a disability, but then the moment I can't hear something or it's loud in the environment, I get a lot of backlash. And so I think that is like the main thing is if you have someone that you're working with in your clinic or something, like I'm scared to work in small clinic again because I've had so much bad experience with it. So it's just finding like little things like you mentioned. Being able to see your lips is so important. Being able to, if I can't understand a word, write it down. I think writing down is a key thing. So just doing that also with clients too, and just not getting frustrated. I think that's another thing is clients get so frustrated. Other technicians get super frustrated, doctors get super frustrated. So I think the biggest thing is just being, like you said, patient and understanding. And for that comment about pushback, I mean, it's not even just thinking about how you're feeling about acting towards something. How do you feel like the person with the disability is feeling? Like they're already nervous to come in. They already don't want to come in. So it's kind of like just putting yourself in someone else's shoes. So I think that would be your biggest kind of way. But yeah, it kind of goes all over.
No, empathy is extraordinarily powerful when we're willing to have it. But yeah, putting, like that kind of experience, like you talk about, how it feels for the person with a disability that is involved in that moment, and putting yourself in, taking that perspective for just a moment to be like, how would I feel if this person were talking to my husband instead of me? Or if in the case of for instance, healthcare, what you often see is with women who are in a wheelchair, physicians don't even bother talking about reproductive health because they just assume women in a wheelchair, A, aren't having sex, or B, aren't having children. And neither of those are true, typically. So yeah, I completely lost my train of thought. So somebody rescue me.
Are there any other questions?
I do have one. I am going into emergency critical care. I've done it for a long, long time, and have often been the one that goes in for the quote unquote difficult patients and clients to discuss things and be the main communicator, because just in general, trying to communicate in those situations can be so difficult. And then having somebody with a disability is just unpredictable in an emergency situation, and how to communicate is just exponentially more important, and exponentially more difficult. So as I go out into my big girl job, this is something that I think is going to be super important going forward, because this is something that I've really wanted to improve in clinics before, but I've never been in the position to be able to bring this to the table. So long-winded story short, are there any like YouTube videos or any like good videos to kind of use as a tool? Because I would like to bring this type of talk to whatever hospital I go to. But I would like the support, because some of the things that you brought in were really key and good.
Yeah.
For a hard of hearing person and someone who's also best friends with a deaf person, I mean, I know in like emergencies, like depending on, and the range is so wide, whether they speak or they don't speak, whether they sign, whether they lip read. If they lip read, the biggest thing is just clear and concise. If they writing it out, like having a piece of paper and a pencil handy at all times. And then also there's apps, like if they are comfortable speaking, there's a lot of apps that you can like speak with, so you can communicate with them to it. They're not 100% perfect but in an emergency situation, I would think that would be beneficial if you're trying to like tell something quick to a client versus waiting for like a relay system. I know those are like kind of beneficial as well, versus kind of like having to write it out and kind of get everything else. There's apps that you can speak into, and it'll like put kind of voice to text, which is I've seen in kind of like emergencies or certain clients that has been kind of useful for kind of those situations, which might help a lot.
Yeah. And another thing I would also recommend is make questions easy enough to answer quickly. I think that is also really important. I mean, you can get a lot more information quickly by, like 20 questions instead of what happened. You can start with specific, what's injured, and then, kind of go from there so you can get a picture, but it's faster. It's a more rapid communication. I think that also might help.
That's interesting that you say that, because we're taught in our clinical skills class to ask like open-ended questions, because if we ask yes or no questions, we might not get the full story. So I don't know if this is a situation where we will ask like those rapid fire questions, but that's like part of our training is to ask like, tell me more, like just tell me about your pet, and to kind of get a better, like we're told not to ask yes or no questions.
Well, a lot of it, this is what I would say is the way you ask questions. Depends on, if you're with a person with a disability, what kind of disability they have. If you've got someone who's got a severe stutter, open-ended questions are going to kill them. They're never going to be able to answer. And it's going to lead to frustration both for you and for the person, and a negative experience. Another example, I think, of how we ask questions, whether we do it quickly to drill down to the most relevant information first, is like Samantha said, in a situation that's an emergency. Like, what is the basic information you have to know in an emergency? And what do you need now? And what can you get in 20 minutes when the dog is under its initial stages of care? And I think kind of conceptualizing possibly information management in that kind of way. So you start off with the basics of what you need to know. And then as you go through the process, I think I imagine there would be more opportunities for expanded communication. And then at that point, you start asking the open-ended questions, would be my guess. But as someone who has not dealt with emergency situations in this manner, I don't know.
Yeah, and that is a lot of what has been done in the past. As one of the big hurdles that I've had issues with is using those type of apps or communication connecting programs, is the lack of medical jargon that they're able to pick up and translate. And
Yeah.
so trying to explain things in an empathetic way. So if their dog is dying, and to try and really explain and give them a reason for it is so difficult. And that's one of the things that really bothers me, is that I can't sit there and feel like I'm communicating well with these people.
And this brings up an actual really important point, because having a certified ASL interpreter does satisfy the need for, making an accommodation for a person who requests it. However, in both the veterinary care environment as well as in a medical care environment, certified interpreters don't always have the specialized information. They don't know the language to get at what you need to get across to the patient. And this is something where there's a really big problem. There just aren't enough people who are certified medical interpreters that a facility can have easy access to them. So what a lot of facilities do is they end up using video relay, for instance. But there's issues with that as well, for not being a good experience for patients either. So it's a sticky wicket, I guess. It's some of these situations are just really difficult to deal with. And I think it's going to require bringing in people who are more aware of these things, who've had some training, who understand both through personal experience of either their own with a disability or a family member or friend, or just, experience with clients and stuff like this, to help make some of these changes and to start conceptualizing better ways to do things. And that's part of the problem, like Dr. Bowie was getting at with, if people with disabilities are essentially basically discouraged from going to medical school or veterinary school, you're never going to get that kind of institutional knowledge built up to help make these internal changes in a way that makes sense for for veterinary practice at large. And that is a big part of why the lack of diversity, disability diversity in these fields is such a problem. So
yeah, to add on to that, like as a hard of hearing student who's trying to get live relay, to get someone in medical terminology, I keep getting those apps for my classes, and they are just not accessible. And I'm fighting with every ounce of my body to be able to say that this is not accessible. So I can only imagine, like, if we, as a person with a disability, if I can't even get it, I can imagine people trying to use it out in the world. So yeah, I'm with you with the apps. I feel you.
we actually, we've had a person who is who's deaf get involved with our program a year or two ago. And when we asked for like anecdotes and things that, he thought people needed to be aware of as part of the training, he talked about hearing, in particular, hearing disabilities and accommodations for those. And so, he pointed out that, if a hearing person has communication accessibility, a deaf person requires the same accommodation, and that medical professionals need to understand that this is not about them, that it's about providing accessibility to those who need it, no matter what the disability is. And he talked about how a video remote interpreter is actually not a preferred accommodation among the deaf population. It's because it's a video, it's a technology, it's not a live person standing in front of you. And he said his experience with his vision impairment as well was there was no way he could see or understand anything that the interpreter is saying. So for a lot of people, VRI, people think is, oh, this will be the thing that solves it, but it's not. And medical professionals tend to think that because they have VRI available, certified and live interpreters are no longer needed. And so what you see in some cases is almost a tyranny of bad technology. Not bad technology, but technology that still isn't at a point where it can meet the needs we want it to meet.
It's incompetent technology. Like,
yeah,
going off what Madison said, like we have Otter AI that it closed captions all of our lectures, and it's ridiculous. Like you cannot, like, imagine for all the students who are still here, like imagine having to learn with just Otter AI. Like that is it's impossible. Like even just mix per kg gets turned into some long elaborate thing, and wow.
Yeah, so I mean, again, and this is part of the problem is you see it's in a lot of areas where, you know, technology will solve everything, but the technology that's being discussed is not technology that people with the disabilities or people that it would be impacting are really allowed into the decision. It comes back to that whole nothing about us without us. It's not just a health promotion thing. It's about how we structure these accessibility options, how we interact with people, you know, all this kind of stuff. And people with disabilities who are never in an internal, who don't have an internal view of how the sausage is made, basically, you know, the profession as a whole is really at the mercy of people who think they know, of well-meaning people who think they know best. You know, and actually, interestingly, that is a criticism of person first language, is that it was developed by people without disabilities, without input from people with disabilities and how they actually felt about it. So yeah, so again, it's one of these kind of things that you end up with things done by people who don't really understand the needs they're trying to meet. And everything just goes wrong when that happens. You end up creating new problems you don't realize you have unintended consequences. So yeah.
Do human hospitals just have staff on all the time for like the emergency service and dealing with this, or is there some like secret thing that the veterinary community is not aware of that's done in the human medical field?
It depends. So a lot of hospitals and healthcare systems, like I said, are going more towards using VRI, the video relay, as a worthy substitute, I guess, for a live interpreter. And it does conceptually have some advantages because, yeah, I don't know for sure, but I would imagine, you know, you'd be more likely to have an actual certified medical ASL interpreter who actually knows the language, with companies that specifically contract with hospitals and other healthcare facilities that use VRI. I don't know for sure, but that's kind of what I would hope. So that can be one option, but again, that only hits one particular slot of the universe of people who have a hearing disability. The other things, again, relying on your best actual resource, I think, for wherever you end up is your local Center for Independent Living. I mentioned them earlier with interpreters. They can help you find interpreters. Again, it is, if someone requests it, the onus is on the facility, on the provider to provide an interpreter. A lot of people with disabilities don't like to rock the boat, so they won't request one. But if they know, you know, if it's made clear through your interactions with them at the facility that you are willing to do this, you know, and that this is something you are willing to offer, so they don't just have to rely on their brother who might or might not know how to say vowel, I guess, I don't know, you know, something basic. I'm trying to think. So they would be your best bet into connecting more with disability related resources within your community. But I think really just because of the sheer lack of certified interpreters relative to the size of the need that would exist if everybody who needed them requested them. I think VRI is the way people are, I think that it's the closest they've come so far to trying a mass medical solution, I think, in some facilities to solve the problem, just like they use video, you know, language translators. You know, I think it's the same kind of concept there. But
I also wanted to hop in I'm so sorry. Finish your train of thought. That as far as like deaf and hard of hearing goes, we're bringing in 3 veterinarians who are deaf and hard of hearing themselves. They've gone through vet school. They've been clients with their own pets. And we're going to have our own 2 students on the panel and hopefully a client as well. And there's going to be a keynote speaker who's going to talk specifically about deaf and hard of hearing. So I know like this presentation was about disabilities in general, but I'm just, since we're on this topic, I just wanted to point it out that one's coming in March. So you'll get a better understanding of how, like even just how the veterinarians work as deaf and hard of hearing people. So
Yeah.
just wanted to put it out there.
And then you'll see exactly how much I'm spitballing and pulling things out of what I hope is right. So, are there any other questions?
Mind if I ask another one real
Go for it.
fast? So what's it called? I guess my passion is certainly shelter medicine. And in that population specifically, we're seeing a lot of intersections with disabilities and poverty as they correlate, especially in situations specifically pertaining to mental health disabilities specifically. Is it like, as we were having the conversation about how hard it is to find certified medical sign language interpreters, is this really, I don't know if this is like a toxic trait coming out, but like like the onus is on us. Should we be really pushing for the next step of taking to do the certification ourselves, and or going into more of like looking into social work certifications to like cover more of our bases?
I think the answer to that question is going to be unique to the individual. It's one of those things that having more people with this knowledge is fantastic. It can do nothing but help the community at large. But it's also can be done at a great cost to yourself. And so I think in a perfect world, yes, do it. Because, you know, especially like you said, for people with the intersection of poverty, mental health, like this is really important. And as you see, you know, animal care is the least, is not the least of their worries, because many, you know, especially people who are homeless and have animals have very strong attachments to their animals. But there's so many intersecting needs at the same time. What I would honestly do, rather than looking into, getting a certification in, some public health or social work kind of thing, I would find out resources in your community to help link people up with services. So Gainesville, for instance, has Grace Marketplace. They have, I think there's some other agencies in town that can help with this kind of stuff. So if you have resources available that you can be a pass through, essentially, like you can say, hey, like here's some people, here's this organization. These are some things they can help you out with to try and do that. In terms of actually interacting with people who have sort of intersecting and multiple layers of traumas, but not quite, not everything's trauma, layers of difficulties, things that present, for whatever reason, present additional difficulties in society that, like, white dudes, straight white dudes don't have to face, intersectionality, basically. It's important, I think, to be culturally competent and to understand how to manage situations in a non-aggressive, non-hostile manner, because I'm sure with animals and people dealing with animals, especially if it's bad news, you might end up dealing with some hostility just in general, and having, so I think actually better than just like some sort of social work certification is actually like communication, de-escalation, sort of ways to, that you can make the entire encounters go smoother. And then as an adjunct, know your resources that are available, make some contacts with people at that agency, find out some information about like, well, if we're doing housing, how do we, what about, can a person who applies for housing, at Grace Marketplace or something, or however they do it, would they allow dogs? Are there, find out if there's other options for places that don't, like that kind of stuff. So I think it's really important to be aware of resources in the community, and some resources in specific that are good for clients with various, mental health, disability, poverty, all this kind of stuff that would be helpful for them, especially in terms of making sure they can live and take care of their animals. Because so many places take away homeless people's dogs. They can't have the dogs in the shelter, so people don't go to the shelter. But, kind of finding out some of the resources, like some of that kind of information, like, hey, you can go here with your pet, or, like for instance, when I worked at Peaceful Paths here locally, like if somebody had to shelter a pet, we had a place we could take them. So a person didn't have to leave their pet behind for their abuser to hurt or kill. So, there's things like that, kind of like the more you know, but having awareness about these kind of resources, staying on top of it, and having connections with some of these agencies that you can direct people to. So it's not just here's their front line, but here's, Rebecca Tanner, and, talk to her about XYZ kind of thing. So the more specific information you can get, and then just, as much cultural competency training for various aspects, communication trainings, I think those, that combined with a really good knowledge of the resources that are available in a situation like where you're dealing with shelter medicine, or that's what you've gone into, are probably your best bets. Because, a social work degree is, it's 4 years. It's a commitment kind of thing. It's not just, so you want to think about what's the best use of your time and what provides the best bang for that time. Like, how can you best benefit through your learning experience and through what you do personally? And some of the stuff you can also advocate at schools and practices to put in place is standards of training, like, de-escalation, So yeah, so I think that's also,
Thank you.
Yeah, sorry, I feel like I'm getting a little bit rambly.
No, not at all. And I just have to say, I really resonated with your statement of empathy being active. It's an active choice that we have to commit to every day. So that's going to stick with me for a little bit tonight. So thank you for a wonderful discussion and all the great information.
I'm glad people have enjoyed it, and my boss is telling me to wrap it up. So
thank you so much.
Claudia is tired of listening to me. So.
No, I'm good. I'm still at the office. If everyone could do the post test, if anyone's still on that hasn't done it yet, we would really appreciate that.
Yeah.
For sure.
And I did accidentally keep it on longer than I was supposed to, but since we've been talking,
no, this is
still technically part of the presentation. So
yes, I've recorded the entire discussion because I thought the discussion was also really, really great information. But thank you so much for coming again, both Claudia and Rebecca. The vet med community is awesome, and we're always open to learning more. So I will be sending all the resources out to everyone. I will be sending the presentation, and then Rebecca, I'm gonna email you once I download this recording about how to disperse this best. I'm gonna do some
excellent and also
technology things.
While I have you in here, before I forget, add me to the mailing list for the
absolutely
yes hard of hearing event that you've got coming up, because that would be interesting for me to. So
yeah.
Because you guys, vet med, and now in the 2 times that we've presented to the vet med audience through Valid, you guys are by far the best audience we have. Like, you're the most engaged.
I agree.
So it's stunning, and it's really fascinating that vet med shows more interest than anybody else does. So
wow, thank you.
So congratulations, you guys.
Oh, hearts everywhere.
Yes, you are what we want others to be.
Yeah. But I will definitely also we have an Instagram. I don't know if you're on Instagram or on Facebook. I'll
Yeah.
send you the links to our organization as well, because
Mhm.
a lot of these discussions are a lot of our events are open to anyone who's
Mhm.
welcome to come, depending on the presenter, of course. And
Mhm.
usually we don't share something on Instagram if it's not open, but
Mhm.
yeah, our definite hard of hearing panel is going to be really great. And then
Yeah.
so we're starting to do a little bit more things, because we know we're the last thing, Claudia, I swear, we're the diversity club, but
Mhm.
it's come to light that every time we talk about diversity, we talk about, color and sexual
Mhm.
orientation, and we always leave out disabilities. So we're definitely trying to address that more and put it more on our radar. So thank you so much for coming. And,
No problem.
thank you so much for your
Thank
time.
you
You
guys.
guys.
Bye. Have a good one.
Bye, everybody. Go home, Claudia. Go away.
Go eat dinner,
Bye.
everyone.
Bye.
Yeah.